All right. Hi, everyone. Thank you for joining us for today's event, What's Hot in Pediatric Infectious Diseases. For your information, all participants' microphones are muted today. If you have any questions, we ask that you please use the Q&A box that is located in the bottom center of your Zoom Windows taskbar. The chat box is also available if you have any questions or technical support questions during the presentation. As a reminder, this webinar is being recorded. The recording will be available on the Prevention Institute website and will be emailed to you in the coming days. My name is Jasmine Ogren. I'm the Sexual and Reproductive Health Program Coordinator with the Saskatchewan Prevention Institute. The Prevention Institute is a provincial nonprofit organization. Saskatchewan is located on treaty lands 2, 4, 5, 6, 8, and 10, and the traditional lands of the Métis people. We acknowledge that our work is carried out on and with people from these lands and are committed to working towards reconciliation and strive to reaffirm our relationships with one another. Our organizational focus is to help all children thrive through primary prevention and the promotion of well-being. We believe that all children, regardless of ability, have the right to the best physical, social, and emotional health possible. We provide education, training, and capacity building across 6 main program pillars: early childhood mental health, perinatal and infant health, prevention of child abuse and neglect, prevention of child injury, prevention of fetal alcohol spectrum disorder, and sexual and reproductive health. One focus of the Sexual and Reproductive Health Program is to provide evidence-based information on topics related to sexually transmitted and bloodborne infections and reproductive health that is accessible to health professionals. By remaining up to date with emerging trends and evidence, we help to ensure that the care we provide is based in best practices that are safe, equitable, and responsive. Here to speak to us today about what's hot in pediatric infectious diseases is Dr. Athena McConnell. Dr. McConnell obtained her medical degree from Queen's University. She completed her pediatric residency here in Saskatoon before going to the Alberta Children's Hospital in Calgary for a fellowship in pediatric infectious diseases and a master's degree in medical education. She's been a member of the Department of Pediatrics since 2007 and is actively involved in clinical work, teaching, research, and accreditation. In addition to providing care to many of the children with HIV in Saskatchewan, Dr. McConnell is involved with the Canadian Perinatal and Pediatric HIV/AIDS Research Group, which is a national organization committed to optimizing research, surveillance, clinical care, and the prevention of pediatric HIV in Canada. Dr. McConnell, thank you so much for being with us today. You can take it away whenever you're ready.
Thank you. And thanks so much for the invite to present. And thanks to everyone who is giving up their lunch or part of the lunch to be part of today's webinar. So today is a webinar on what's hot in pediatric infectious diseases. And really, when I was thinking about what's hot in my field, I was thinking about events that have happened in the last year that I think really have the ability or the capacity to have a huge change in my practice. And hopefully, some of the information that I'll present will also cause you to think about what you might be changing in your practice as a consequence. Okay, so we have 6 objectives. So by the end of the presentation, participants will be able to discuss the rate of transmission of HIV due to breastfeeding, reasons why an undetectable maternal plasma viral load can still result in HIV transmission, be able to discuss evidence regarding means that we can put in place to reduce the risk of transmission from a breastfeeding HIV-positive birthing parent to the infant, talk about the recommendations from CPARG regarding feeding options, of infants born to HIV positive birthing parents, which include breastfeeding. And then changes in the duration of zidovudine, AZT, in infants born to low-risk HIV positive birthing parents, and changes in the options in terms of treatment of pediatric chronic hepatitis C infection. So this is my disclosure slide. You can see that I do research with the Special Immunization Clinic Network, and which is as well as being a member of CPARG, and then I am on the Speakers Bureau and advisory boards for 2 pharmaceutical companies listed. So a little bit of a quiz, just to get some brain cells discharging, maybe. I know it's lunchtime. So question 1, which of the following statements regarding breastfeeding among HIV positive birthing parents is true? And you don't need to answer out loud. You just look at the various options and pick the option that you think makes the most sense. So I've given you A, B, C, and D. We're going to move on to question 2. Which of the following statements regarding previous studies on strategies to reduce the risk of transmission of HIV from an HIV positive breastfeeding parent to the infant is true? We're going to skip ahead to question 3. In which of the following maternal situations is the infant at low risk of HIV maternal to child transmission, and therefore can be offered a lower duration of zidovudine after birth? So which of these situations related to mom is true, such that we can offer the baby a smaller duration of zidovudine? And then question 4. Which of the following statements is true regarding the treatment of chronic hepatitis C in Canadian children? And like I said, just a bit of a quiz, just to get ourselves thinking about various things. Okay, so let's start with HIV. So this is a slide with data from the Public Health Agency of Canada, and this is data from 2020. And in 2020, PHAC estimated that there were just under 63,000 people living with HIV in Canada, almost a quarter of whom were women. And among women living with HIV, almost 70% were between 20 and 39 years of age, and therefore of reproductive age. We've known for a long time that if we don't intervene in an HIV positive mom, that the risk of HIV transmission from mom to child is somewhere between 15 and 30%. And that's the estimated risk from a number of different studies from literally all over the world. We also know that if we are able to intervene for the parent and the infant, that the risk of transmission from parent to child is reduced significantly, and it's less than 1%. The risk of transmission is the highest actually in the last month prior to delivery. So between 36 weeks all the way to labor, and that's about when the estimated risk of transmission is about 50%. So between 36 weeks to labor is about 50%, and then the act of actually giving birth confers another 33 to 35% risk, and then you can see that there's a much smaller proportion of transmission risk actually during pregnancy. But certainly, we certainly don't say that the parent can't transmit HIV during pregnancy, but just that the risk of transmission is much highest either between 36 weeks and all the way into labor. We also know that even if we do everything right and that parent has been placed on HIV medications, and we've supported that parent to give birth safely, and the infant is placed on antiretrovirals, that if we were to do nothing else beyond that, and we allowed that HIV positive parent to breastfeed, that there is an additional risk of HIV transmission of about 14%. And that's through meta-analysis of data coming to us from a number of different settings. There are a lot of reasons or a lot of factors that influence the risk of mother-to-child transmission via breastfeeding, and I've given you a partial list of those. The first would be mixed feeding, or the practice of having baby breastfeed as well as formula feed, or breastfeed and have solids. So that's mixed feeding. And the reason why mixed feeding increases the risk is that the proteins in formula and proteins in solid food can actually abrade the lining of the intestine. So you get microscopic abrasions, and those microscopic abrasions actually then act as portals of entry for HIV that would be present in anything that was ingested. The duration of breastfeeding certainly is a risk factor for the transmission of mother to child with respect to HIV. So the longer that you breastfeed, the higher the risk of transmission from parent to child. The HIV viral load of the birthing parent plays a role as well. So parents who have higher HIV viral loads in their plasma have a higher risk of transmission to their baby through breastfeeding. And additionally, if mom's HIV viral load in their breast milk is high, then that also correlates with an increased risk of transmission. And interestingly, the breast milk HIV viral load can still be high or detectable, even if mom has an undetectable plasma HIV viral load. Moms or birthing parents who have a lower CD4 count have a higher risk of transmission of HIV to the baby via breastfeeding. And then the presence of mastitis or cracked nipples also influences the risk. Many who've joined us on this webinar have heard of U equals U, and U equals U translates as undetectable is untransmittable. And it's a concept that actually only applies to sexual transmission. So if we have a serodiscordant couple, so we have one partner who's HIV positive and we have one couple who's HIV negative, if the HIV positive partner has an undetectable HIV viral load, we've seen from really good studies in the past decade that the risk of transmission from the HIV positive partner to the HIV negative partner is effectively zero. Unfortunately, this doesn't occur though in the setting of breastfeeding. We have seen lots of well-conducted studies that have told us that even when that birthing parent has an undetectable plasma HIV viral load, that infants can still get infected. And a lot of that is because the birthing parent who's HIV positive will have CD4 T cells in their breast milk, and CD4 T cells are secreted in breast milk of both HIV positive and HIV negative birthing parents. So it's not that HIV positive birthing parents are somehow special. This is something that occurs in all birthing parents. They will have CD4 T cells. Unfortunately, in HIV positive birthing parents, the T cells that they secrete in their breast milk are either latently infected or not latently infected, but actually actively infected and activated CD4 T cells. And those CD4 T cells that are found in breast milk actually secrete HIV antigen better than the comparable cells that's found in blood. And interestingly, even if you were to take breast milk from birthing parents who want to breast milk or who want to breastfeed, if you were to spin those down and actually take out the CD4 T cells, you can still detect HIV RNA in breast milk that don't have any T cells in them. So U equals U definitely does not apply to the breastfeeding situation. This doesn't mean that we wouldn't want to support breastfeeding. Certainly, the World Health Organization still recommends that breastfeeding is the safer option in countries where formula feeding leads to higher rates of diarrheal diseases. We know that breast milk is nutritionally complete and that there are immune effectors in breast milk that enhances baby's immune system. We also know that breastfeeding promotes psychological development. So there are lots of reasons why breastfeeding would be something that our healthcare team and our healthcare systems would want to promote. So how can we make it safer for HIV positive birthing parents who want to breastfeed to actually have that option? And we go back to lots of studies done predominantly in low resource settings, because those are the countries where the World Health Organization has promoted breastfeeding. And these are studies where they've looked at placing mom and or the infant on antiretrovirals, having antiretrovirals that are either monotherapy or combination therapy, so 2 or even 3 drug regimens, and then studies where they've looked at variable duration of prophylaxis. So the best of these trials actually had an acronym of PROMISE. And don't ask me what PROMISE stands for, because I'm not sure that I remember what PROMISE stands for. So PROMISE was a randomized open label trial conducted a long time ago, conducted over a span of 3 years. It enrolled enrolled actually mother-infant pairs in 7 countries from 14 different sites, and it enrolled mother-infant pairs who were in the postpartum period. The women that came into the study actually came or were part of 3 groups. The biggest proportion of women who were enrolled into the study actually had participated in an antepartum study with the same premise. So they had previously participated in the PROMISE antepartum study, and this was over or just under 85% of the women had participated in the PROMISE antepartum study. And as part of the PROMISE antepartum study, they had received HIV treatment during their pregnancy, labor, and postpartum period. About half of those women received zidovudine monotherapy for their pregnancy, as well as getting a single dose of nevirapine at or just after having given birth. And then half of those women were actually on triple therapy. So they had received 3 drugs. There was a smaller proportion of women who had not been on any HIV antiretrovirals at all, including during the intrapartum period or in the immediate postpartum period. And then there was just under 2% of the women who were diagnosed as HIV positive during labor. And because they were diagnosed as HIV positive during labor, they actually got or they received intrapartum zidovudine, as well as a single dose of nevirapine. And then afterwards, they were given a tail, or between 6 to 14 days of 2 drugs, so tenofovir, emtricitabine. All of the infants that were recruited had to have had an HIV-1 nucleic acid test. So they needed to have a negative HIV PCR prior to enrollment. So the randomization occurred in the first 2 weeks postpartum, and the mother-infant pairs were randomized 1-to-1. So the pairs themselves were randomized either to a maternal arm or to an infant arm. So just remember that these are actually mother-infant pairs that were randomized. So it's not that the moms got randomized into the maternal arm and the infants got randomized into the infant arm. The pairs themselves, the moms and their babies, were randomized to either the maternal arm, where the mom received tenofovir, emtricitabine, and lopinavir ritonavir, so a 3-drug regimen until randomization ended. And the infants of those moms received nevirapine for 6 weeks. So that was one arm of the study. The other arm of the study was an arm where the moms received no further antiretroviral treatment, and the infant received nevirapine until randomization ended. And randomization ended at 1 of 4 time points, whichever came first. So either 42 days after the last breast milk exposure, the infant was 18 months of age, the infant was diagnosed with HIV-1, or the study was ended for that particular mother-infant pair because of severe toxicity related to being on antiretroviral therapy. So what were the results? So the primary endpoint really was the detection of HIV-1 infection in the infant. And that was defined as 2 positive HIV-1 nucleic acid tests. So 2 positive HIV PCRs, that was the primary endpoint. There were just over 2,400 mother-infant pairs that were randomized 1-to-1. And what did they find? So in the arm where the moms got triple therapy and the infant received nevirapine just for 6 weeks, as well as in the arm where the mom received no further therapy, but the infant received nevirapine, the rate of transmission was less than 1% at 12 months of age. So really promising, really very promising results. We do have to remember that in both of those arms, we would have had the majority of women would have just come out of the PROMISE antepartum study and likely had very low or undetectable HIV viral loads. So even in the group where the moms received no further HIV therapy, they would have started out likely with a very low or undetectable HIV viral load, even if they had been pulled, even if their treatment had been pulled and it was just their infant that was getting treatment. So, like I said, that was probably the biggest study that was carried out, and it still concluded that breastfeeding carries a risk of HIV transmission to infants, slow, but certainly not zero, and that breastfeeding carries a risk of HIV transmission even when moms are on triple therapy against HIV, and then understanding that although the study itself didn't quantify the HIV viral loads in the parent, the vast majority of those positive parents likely had undetectable HIV viral loads in the early part of either in the early part after they had discontinued, or they would have been undetectable for the whole entire duration if their HIV therapy was never stopped. We know from the PROMISE study, as well as other studies that came before that when we give antiretrovirals, we are able to decrease the risk of transmission from about 14% to less than 1%, and that we can intervene either by giving mom triple therapy or by giving the infant an antiretroviral. So interestingly, the PROMISE study was done with nevirapine. There have been other studies where the infant has been given zidovudine, but there actually has been no study that have looked at giving infant triple therapy and looking at what the rate of transmission would be. So as I said, the PROMISE study was conducted in 2011 to 2014. The results of that study were published probably in 2015 or 2016. And there haven't actually been very many new studies since the PROMISE study. So interestingly, we've known now for quite a long time that we can intervene and reduce the risk of transmission to less than 1%. And the recommendations up until this year have been very strongly worded so as to have healthcare teams discourage breastfeeding amongst our HIV positive birthing parents. And so no new studies, no new conclusions, no new information, but we've had a change in recommendations, and we'll go over what the change in recommendations are. So why might recommendations have changed? Well, certainly it's not new that we've had requests from HIV positive birthing parents to allow them to breastfeed. What I think has changed over the years is our comfort in being able to discuss the recommendations and being able to discuss what the risks and benefits are to the HIV positive birthing parent. We've also had, I think, not surprisingly, a recognition that we have families where there might have been a previous infant who was breastfed before the parent was diagnosed with HIV, and we then have the situation where we have families who want to offer or want to have the same experience. Maybe the birthing parent has come to us from a country where HIV has been endemic and where breastfeeding has been allowed. And certainly we know from our epidemiology that approximately 15% of our HIV positive women living in Canada are now in that group. So roughly 1 in 6 or 1 in 7 Canadian women living with HIV actually have come to us from an HIV endemic country. And so there's a bit of a gentle pushback because, you know, they've had the experience where they've had 1 to 3 children born after they were diagnosed, and they were safely allowed to breastfeed, and their infants never became infected. So lots of reasons why there's been a shift, at least in some of the recommendations. So in January of this year, so just very early in the early part of this year, we actually had 2 statements that came out. One of those statements came from the American group. So it came from DHHS, so the Department of Human Health Services, of Health and Human Services, and they provide the guidelines around treatment and prophylaxis of HIV positive individuals. That actually was released on January 31. Interestingly, 5 days earlier, the Canadian Pediatric and Perinatal HIV/AIDS Research Group also came out with some recommendations that, and both groups conclude that breastfeeding may be considered for HIV positive birthing parents. Now, there are some differences in those 2 documents. The principles that both of those groups agree on is that formula feeding is still the safer option. When we think about feeding options for infants born to HIV positive birthing parents, formula feeding carries 0 risk of transmission of HIV. The other principles in agreement are that if we are going to offer breastfeeding as an option, that the birthing parent and the infant should be on antiretrovirals active against HIV, and that both the parent and the infant need to undergo regular testing, and that mixed feeding, so either breastfeeding plus formula or breastfeeding plus solids, should not be allowed. So both groups are adamant that if we're going to discuss breastfeeding as a feeding option, that discussion between the birthing parent and the healthcare team needs to occur well before delivery. So ideally, this is not something that we talk about the day before mom is getting discharged. but that this is something that occurs while they're still pregnant, and can think about what the implications are for them, for the infant, and for their family. Again, part of our discussion should be that there's no risk of transmission when you formula feed, and that we can reduce the risk of transmission related to breastfeeding, but we can't eliminate that risk. So the risk is still there. And if you're thinking about a feeding option that carries no risk of transmission, then that then would not be breastfeeding. So going to detail with respect to what the recommendations are, and just as a reminder, these were published just in January of 2023, and I've given you the reference below. So that birthing parent needs to have been fully adherent to antiretrovirals and should have a sustained undetectable HIV viral load, ideally preconception. So the ideal state would be that you have a birthing parent who has been on antiretrovirals before they even got pregnant, and that they were fully adherent and had undetectable HIV viral loads starting before they got pregnant and throughout their entire pregnancy. That's the ideal state. And that and you would keep the birthing parent actually on antiretrovirals for the whole entire time that they're breastfeeding. That we place the infant on antiretrovirals. Sorry, guys. Preferably, we place the infant on triple therapy, so zidovudine, lamivudine, and nevirapine for at least 4 to 6 weeks, and then nevirapine would continue, and we wouldn't stop nevirapine until 4 weeks after breastfeeding stops. There are some alternative options, one of which would be just to continue the infant on triple therapy until 4 weeks after breastfeeding stops, or just doing nevirapine entirely. So starting nevirapine at on day 1 of life and doing only nevirapine until 4 weeks after breastfeeding stops. The recommendations also say that we should be encouraging weaning by 6 months. So weaning from breast milk by 6 months to minimize the duration of mixed feeding. So mixed feeding in this sense would be the practice then of introducing solids, usually around 6 months of age. And so we would want that infant to be off breast milk before they start solids, and at no time would we encourage breast milk plus formula at the same time. The birthing parent, we would want to do HIV viral load monitoring every 1 to 2 months. And the infant is monitored as well. So the infant is monitored at birth, and then gets blood work drawn at 2 weeks and at 4 weeks of life, and then every month thereafter until a minimum of 2 months after breastfeeding has stopped. That's a lot of work, guys. Like, it's a lot of work for the birthing parent. It's a lot of work for the family, and we need to make certain that the birthing parent and their families are well aware of exactly how much work it is. We need families or birthing parents that need to be fully committed to be adherent not only to their therapy, but also to their infant therapy, as well as being fully committed to the need for regular testing. But it isn't just about being committed. It's so as a team and as a system, we need to recognize that we are going to have birthing parents and families where the option of breastfeeding carries with it significant logistical challenges. So how do we contact them to discuss medication challenges or remind them about upcoming blood work or a clinic appointment? So do they have a phone? Can they accept long distance phone calls on their phone? Do they have a texting plan? Will they run out of minutes before the month is up, and therefore we can't contact them? How do they get prescriptions refilled? So if their nearest pharmacy is an hour away and they don't have reliable transportation, how do we get them their meds? And then importantly, how do they get to a lab so that they can get blood work done on a regular basis? So it's a lot of work for the HIV positive birthing parent and their families. It's also a lot of work for our healthcare teams. And we need to recognize that in order to support these birthing parents well, it's a lot of resources that need to be put in place. Okay. And then lastly, the question then is, is breastfeeding is breastfeeding something that we can pursue for every HIV positive birthing parent in Saskatchewan? And so just as a bit of a, I think, not to say that we couldn't do it, but even in the PROMISE study, 10% of those mother-infant pairs didn't complete the study. And they didn't complete the study because they were unable to adhere to the regimen. The mother and or the infant weren't able to get to the clinic. The clinic wasn't able to contact the parent. Blood work wasn't performed. So, even in, we have great data from the PROMISE study, but 10% of those mother-infant pairs actually didn't complete that study. So just some things to think about. And lastly, taking a look at our data, certainly in Saskatoon, in the last 5 years, 50% of the HIV positive women that we followed are repeat moms. So moms who have given birth previously and have had the experience where their infants have been formula fed and none of their infants were infected. And so it may not be an option that many of our birthing parents will think about will work for them. So food for thought. Okay. So sticking with HIV, let's take a look at the duration of infant antiretroviral therapy in the setting where the birthing parent is not breastfeeding. So I've told you this before, we know that if we don't intervene with respect to giving moms and babes antiretrovirals, that the risk of transmission during pregnancy and labor for HIV is somewhere between 15 and 30%. And that if we do intervene, and we intervene optimally with respect to giving that birthing parent antiretrovirals during the pregnancy, during labor and delivery, and we place that infant on antiretrovirals, that the risk of HIV mother-to-child transmission is less than 1%. And prior to March of 2014, the Department of Health and Human Health Services, which is I've mentioned them before, they're an American organization, recommended that all neonates exposed to maternal HIV should get zidovudine for at least 6 weeks. So this was all comers, and that was the recommendation. In March of 2014, DHHS revised the recommendation to say that neonates may receive zidovudine for 4 weeks if the following criteria were fulfilled. So that birthing parent had received combination antiretroviral therapy during the pregnancy was consistently suppressed with respect to HIV viral load, and that there were no concerns related to maternal adherence. So that was a big deal. Going from 6 weeks down to 4 weeks was and still is a game changer. So that's a third less time that we had to have families who needed to worry about giving their babies zidovudine twice a day. So twice a day, every day for 6 weeks. And now we were saying, hey, you can do zidovudine twice a day, every day, but now you only need to do it for 4 weeks. So why did this happen? So interestingly, it happened because our European counterparts had been doing something very similar for quite some time previously. So starting back in 1998 in Ireland, the Irish guidelines recommended 4 weeks for all infants exposed to maternal HIV. And they did this with no studies. The Irish guidelines were extrapolated from the finding that if you gave 4 weeks of zidovudine for occupational and non-occupational exposure to prevent HIV, that the rate of transmission was super low. So the Irish thought, if it works for adults, there's no reason why it shouldn't work for babies. And so the Irish guidelines in 1998 were 4 weeks. And Britain, 7 years later, decided, you know what, we're going to do the same thing. Again, no studies to support that this was a good idea, at least in the infant setting. So the Irish guidelines came out in 1998, and a decade later, there was a cohort study that looked at what the effects were of giving infants zidovudine for only 4 weeks. So they did a cohort study of all infants that were born between 1999 and 2008. And the infants were given 4 weeks of zidovudine only, unless the moms actually had a risk factor. And you can see the list of risk factors there. And what did they find? Oh, so sorry. So they had just under 1,000 infants in that 10-year span. You can see that just over half, or about 60% of them, were given just zidovudine, and so their moms had fulfilled all of the criteria above. There were about a third where the infants were placed on triple therapy because moms had met at least one of the above criteria, or they were placed on double therapy, so zidovudine and lamivudine. But the vast majority, or at least half, were actually just on zidovudine monotherapy. Their vertical transmission rate was just over 1%. So they had 10 infants who were infected. And interestingly, of the 10 infants who were infected, 9 of those 10 infants were situations where they were either infected at labor, or between 36 weeks and labor, or their moms had been diagnosed late in pregnancy and therefore had received approximately a week of antiretrovirals. And so there was only one infant where the mom had been placed on antiretroviral therapy and had, I think her highest HIV viral load was 53 copies per mil, and that particular infant was diagnosed to be HIV positive at 6 weeks of age. So when you look at when you look at their data, really, that's a super low vertical transmission rate. They also reported, however, on their adverse events. And the most common adverse event actually was hematologic. So either neutropenia or anemia in 69 infants, 69 of 111 where they had drawn CBCs. 2/3 of these adverse events, so either neutropenia or anemia, had resolved by 3 months. Okay. So in 2014, this was the recommendation that infants could be placed on zidovudine monotherapy for 4 weeks if moms had received, or if the mother-infant pair could satisfy all 3 conditions. And the rationale given was that certainly in other countries, there's no increased rate of vertical transmission when you look at 4 weeks versus 6 weeks of zidovudine, and there is a reduced risk of hematologic side effects when you give 4 weeks versus 6 weeks of zidovudine. So no increased risk of transmission, and the rate of adverse events is lower when you give 4 versus 6. And then earlier this year, there was another change to infant zidovudine duration. And this time, DHHS is saying that infants may be offered zidovudine for 2 weeks only in situations of low risk of mother-to-child transmission. So again, why did the Americans make that change? Well, again, based on experience from overseas. So this time we're looking at evidence from Germany and Austria. In Germany, Austria, since 2014, their guidelines have been that neonates will get 2 to 4 weeks of zidovudine unless it's high risk. And high risk, they define as a maternal HIV viral load of greater than 1,000 copies at or near delivery, or incomplete maternal antiretroviral therapy. And they took a look at their, and so they also did a study of between 2010 and 2016 of 321 mother-infant pairs. The vast majority of those moms had an undetectable HIV viral load at delivery. And just for everyone's sake, an undetectable HIV viral load typically is either less than 50 copies per mil or less than 20 copies per mil, and it really depends on the assay that you're using. In that particular study, about 40% of those infants received 2 weeks of zidovudine, and then the remainder received 4 weeks of zidovudine. What they found was, and I know that these are relatively small numbers. You're looking at about 150 infants, or somewhere between 150 and 180 infants in each arm. But the rate of transmission from mother to child in the group that received 2 weeks of zidovudine was 0. There were no transmissions. And then in the group that received 4 weeks, there was the transmission rate was 0.5%. So very low risk of HIV transmission. And then you can see in that bottom picture that when you give AZT for 2 weeks versus AZT for a month, that there was a lower rate of anemia when you reduce the exposure to zidovudine. The United Kingdom and Ireland also took a look at their data. So they took a look at 2,500 mother-infant pairs between 2012 and 2014. And neonates were given 2 weeks of zidovudine if those 2 criteria were met. So sorry, 3 criteria were met. And the rate of mother-to-child transmission in infants who were given 2 weeks of zidovudine was 0.27% overall. So in that whole entire cohort, and much less than that, if you had a mom whose HIV viral load was less than 50, the mother-to-child transmission rate was 0.14%. So very, very, very low. So as of January of 2023, the DHHS guidelines now say that neonates can be given 2 weeks of zidovudine if all criteria in the birthing parent. So they did not seroconvert during pregnancy. They've been on treatment for at least 10 consecutive weeks. They've maintained HIV viral suppression, defined as 2 HIV viral loads 4 weeks apart. They're less than 50 copies per mil. Their HIV viral load is less than 50 copies per mil on or after 36 weeks gestation, and that they have no adherence concerns. And so in that very select group that are very low risk for HIV transmission, you can safely give neonates 2 weeks. I know that there are some mother-infant pairs who will meet criteria, but I don't know that we have very many in Saskatchewan who can meet all 5 criteria listed above. And so I would suggest, I suspect that that many of our neonates will still continue to need 4 weeks of zidovudine. Okay, so we're going to move on to hepatitis C. This, again, is data coming to us from the Public Health Agency of Canada. And this is data from 2019. And in 2019, there were just over 11,000 reported hepatitis C cases in Canada. So just over 11,000, that's both acute and chronic hepatitis C. There were just under 3,000 cases of chronic hepatitis C in Canada, and 69 cases among those who were 14 years and under. The greatest increase in chronic hepatitis C actually occurred among children 0 to 5 years of age. They accounted for 59% of the hepatitis C cases. They accounted for 59% of the hepatitis C pediatric cases, so defined as less than 15 years of age in 2019. So we don't have a lot of chronic hepatitis C in Canada, but certainly still worthwhile thinking about how we treat them, knowing and understanding that the risk for complications related to hepatitis C increases with the duration that you're infected. So it's not that we have kids who are coming in with hepatocellular carcinoma or cirrhosis secondary to hepatitis C, at least during their childhood years, but then they're at risk for getting those complications at a younger age compared to a cohort who would have acquired hepatitis C as an adult. This is data coming to us from the World Health Organization, and I put it there just as a reminder that that around the world there are 6 hepatitis C virus genotypes. The vast majority in Canada are HCV genotype 1. But we have a smattering of a genotype 2, 3, and 4. And you can see that depending on where you live in the world, you will be you are at risk for other HCV genotypes. So the treatment options for chronic hepatitis C before 2011 were not great. So the treatment options really were interferon gamma by itself, or interferon alpha, or interferon plus ribavirin. The interferon was given by injection, sub-Q, either given 3 times a day, or you could get it once a week if you got the pegylated interferon. Lots of side effects related to interferon. And although ribavirin was typically well tolerated. The duration of treatment was anywhere between 24 and 48 weeks. And you can see that depending on the genotype you have, the rate of response, so it's sustained virologic response defined as undetectable hepatitis C RNA at the end of treatment and for 6 months afterwards. So the rate of sustained virologic response was only 40 to 50% if you had genotype 1, which is the predominating genotype in Canada. If you had genotype 2 or 3, then your sustained virologic response rate was significantly higher. And certainly if you had genotype 2 or 3, typically the recommendation would be that you would get 24 weeks of therapy. And if you had genotype 1, the recommendation would be that we would give you 48 weeks of therapy. So it's a long time. In 2011, though, there was a bit of a game changer with respect to chronic hepatitis C, and that was with the approval of direct-acting antivirals. So as opposed to interferon, which work indirectly, interferon worked predominantly because it stimulated your natural killer cells and your T cells to release cytokines that would then combat hepatitis C. Direct-acting antivirals do exactly what they say. So they were medications that worked at the level of the virus to either inhibit viral protease or inhibit viral polymerase. And that was their method of action. And in 2011, or starting in 2011, we started having approvals for a number of direct-acting antivirals. They were approved for 18 years and older. Therapy duration was 12 weeks. So not 24 and not 48, but 12 weeks of therapy. And depending on which DAA you were on, it was either active against one or multiple hepatitis C genotypes with a great success rate. So success rates of greater than 90%. But really limited to patients who were 18 and older. So in 2020, we got a bit of a reprieve for pediatric treatment. So in 2020, there were 2 medications, 2 DAAs that were approved for the treatment of chronic hepatitis C, in patients who were at least 12 years of age. So we had one DAA that was active against hepatitis C genotype 1 that was approved for 12 years and up. And we had one DAA that was approved for the treatment of chronic hepatitis C that was pan-genotypic. It actually covered genotypes 1 through to at least 4. But again, you had to be 12 years of age. But they came as pills. And so not great options if you had someone who couldn't swallow pills or who wasn't at least 12 years of age. So the big development really for chronic hepatitis C in children came in June of 2022, and that was with the approval of one direct-acting antiviral. I would try to pronounce it, but I would butcher it, really. So probably one of the reasons why trade names are commonly used for the DAAs, just because the pharmaceutical companies have chosen names that are impossible to say quickly. So this particular DAA has actually been out on the market for quite some time, but the new development was that in June of 2022, Health Canada approved them for the treatment of chronic hepatitis C down to 3 years of age, as long as you weighed 12 kilograms. And interestingly, it comes as granules for the younger patients, and duration of treatment is 8 weeks. So certainly much better than 24 or 48 weeks, and even still it's better than 12 weeks of therapy. And with this particular DAA, it is pangenotypic, so it is 1, 2, 3, and 4. Okay, so that was the end of what's hot. And then just looking at that quiz again. So question 1, the right answer was C. So infected, latent, and activated CD4 T cells in the breast milk of HIV-positive birthing parents secrete HIV antigen effectively. Just going over some of the wrong answers. So the additional risk of HIV transmission in the absence of prophylaxis is around 15%, so it's 15%. There is a risk of HIV transmission from an HIV-positive birthing parent who has an undetectable plasma HIV viral load, and the longer that you breastfeed, the higher your risk is of transmitting HIV to the infant. Question 2, which of the following statements regarding strategies to reduce the risk of transmission of HIV from an HIV-positive breastfeeding parent to the infant is true? And really it's statement D, which is that there is a lower risk of transmission when either the infant or the birthing parent is on antiretrovirals. So we can reduce it, but we can't eliminate the risk of transmission. Question 3, in which of the following maternal situations is the infant at low risk of HIV maternal to child transmission and can be offered reduced duration of zidovudine? And the answer was D. So an HIV viral load undetectable throughout the 3rd trimester with some blips of 45 copies per mil at 37 weeks and delivering at 38. So in order to be considered for 2 weeks of infant AZT, you can't have seroconverted during pregnancy, and so that eliminated A. B, the HIV viral load of 40 copies per mil and at 34 weeks and delivering at 36. So the kicker there is that you have to have had a viral load of less than 50 past 36 weeks gestation, and then your HIV viral load has to be consistently below 50 copies per mil. And then lastly, which of the following statements is true regarding treatment of chronic hepatitis C in Canadian children? And again, the correct option was D, which is that options for treatment of hepatitis C for children as young as 3 were approved in 2023. So in summary, we know that breastfeeding is associated with the risk of HIV transmission, even in a birthing parent with an undetectable plasma HIV viral load. We have means to reduce the risk of transmission, but we can't eliminate the risk of transmission from an HIV positive birthing parent to the child. And therefore, breastfeeding can be considered with certain HIV positive birthing parents. Zidovudine can be given for 2 weeks in infants born to low-risk HIV-positive birthing parents that meet certain criteria. And we now have hepatitis C treatment options for patients that are at least 3 years of age and weighing at least 12 kilograms that the kids can actually take. So we're not asking them to swallow horse pills. We're actually we're giving them an option that they can easily swallow. And I'm available for questions.
Awesome. Thank you so much. It looks like we do have one question. With
Sure.
advancements in HAARTs, why are we still using zidovudine and nevirapine, which are about 30 years old?
Great question. And honestly, it is because so those were the options that were available at the time that the studies were being conducted. So we have the greatest experience with them. And there are now, I mean, the last really good study looking at infant treatment options was really done. It was, done around 2013, 2014. And there's no appetite anymore to look at newer treatment options. So until someone can gather 3,000, 4,000, 5,000 mother-infant pairs to look at options other than zidovudine or nevirapine. So doing either zidovudine compared to triple therapy or nevirapine compared to triple therapy, we're just not going to get the data, right? And so we're stuck with the data that has been gathered for us. And I don't know of any institution that would now give REB approval, to be honest.
All right. Oh, there might be another question. Let's see. Someone added, we can't do a viral load from up north, so I would say we can't allow breastfeeding because we can't follow that plan.
Yeah, and I completely understand, right? And that's why it's difficult. I know it's going to be difficult for some families who live in communities where access to testing just isn't going to be quick. And even for some families where they're living in communities where you can get access, like, I mean, there might actually be families in Lloyd and Saskatoon and Regina and PA, but if they can't get to a testing facility on a regular basis, it's going to be difficult to offer breastfeeding. Yeah.
All right, I think that's all the questions. Thank you again, Dr. McConnell, for your presentation and for sharing your knowledge with us today. When you close the window, you'll be directed to a link where you can complete a short survey evaluation of this session. Completing these evaluations helps us create programming and resources to support your work, and we really appreciate you taking the time to complete them. So thank you again, and I hope you all enjoy your afternoon. Bye.